morning, everyone. I just wanted to give you a little bit of a minute or two of questions like, is he actually going to show up? Is he actually going to come from the federal government and be facing the music here? Well, yes, the answer is I am here today. I actually live in Chicago. As mentioned, I'm Stephen Konya. I work for the U.S. Department of Health and Human Services, specifically within the Office of the Assistant Secretary for Technology Policy, / formerly known as the Office of the National Coordinator for Health IT. It's a very big mouthful, but what I want to do with today's presentation, I've got a short one, is just kind of whet your appetite, so hopefully we can have some really good questions after that. So this way you kind of know some of the questions to ask me versus asking me ones about other agencies that have nothing to do, like drug development. That's not my area. But hopefully this will also give you kind of a quick crash course on, number one, how the state of health IT and digital health adoption in the U.S. has evolved, kind of where it started and how we got to where we are. Number two, what my agency specifically and what we've done to help support that as well as continue to do that. And then number three, how we leverage all of that to support innovation in digital health and health IT going forward under any administration, under any kind of climate. So with that, here's the evolution, and I've used this slide a few times in the past, but it kind of shows there's kind of three major acts, if you will, of major pieces of legislation over the years that have gotten us to where we are today. There was a comment made from the audience before, and I think it was just a guess or kind of throwing out there a number of there's room to improve when it comes to digitizing the healthcare ecosystem. And actually, I'm going to contrast that a little bit with some more hard numbers. So, if you go back to 2004 and the Bush administration, that's where our office was created within HHS, and it served a role as not only advising and working underneath the Secretary of HHS and working across all HHS agencies, but also being the primary coordinator to work with the White House on all health IT adoption in implementation. And so this was back in the age after a very tumultuous economic time with the dot-com bust. And this was a time where there was this was also post 9/11, and there was a lot of need for data sharing across the Justice Departments and so on. And in healthcare, we adopted a czar, if you will, or a coordinator to try to coordinate all that information sharing, not only amongst federal agencies, but also in the industry and in the marketplace. At that time, and actually even between then and 2009 when the HITECH Act was passed, the amount of information that was in a digital format in healthcare was actually less than 10%. It was around 8%, I think. And then with the passage of the HITECH Act in 2009, which also followed a very tumultuous time in the recession that we had in the mid-2000s. It was actually designed less about improving healthcare and getting it all digital. It was really taking advantage of the fact that we had certain parts of the economy that were laggards in adopting technology, right? And healthcare probably being the most atrocious at it at that time, with less than 10% of it being digital. And so the idea was, how can we evolve getting the adoption of technology into healthcare, this multi-trillion-dollar industry, and use that as a way to spur more economic activity and growth? And so it was really a way about fostering more adoption of technology and innovation, and it laid out kind of a foundation for three things. And one of the things it did was it created us not just an executive order, but it statutorily created an agency known as the Office of the National Coordinator. And we kind of grew from there to help implement meaningful use alongside CMS. But the goals were get it all digital, move from that 10% to near 100%. Once it's digital, make it interoperable so the data can flow for the right purposes, the right time, the right place, all of that. And then ultimately to hopefully just focus on, once it's all digital and interoperable, how do we then focus on taking advantage of all that interoperable, accessible information? How can we use it to drive down costs, create better outcomes, better experience, more efficiencies, all those types of things? So the HITECH Act is really which came out, and it set these huge incentives, these carrots. It was more focused on that to kind of get the industry to adopt that. Fast forward to 2016, by that time, 80% of the market was now in a digital format. So you can check the box on getting it digital, but we still had a lot of problems with it being interoperable. We had state and regional-based health information exchanges that kind of tripped through getting implemented. Some states did better than others. And that was more network-to-network exchange at the time, but endpoint-to-endpoint was still a big problem, and especially between different stakeholders, so payers to providers to pharmacies to et cetera. But the 21st Century Cures Act was a really a great piece of bipartisan cooperation. It was signed into law right at the end of the Obama administration and fully supported in the first Trump administration with its implementation. And it was really about how do we take all this digital information and close those gaps on where there's interoperability challenges, and then start to evolve into that phase of responsible use and leveraging it for all that greater good. And this is obviously a very high-level summary, but the idea is you had these three very important pieces of legislation that helped advance us to today, where we're now upper 90s as far as the amount of healthcare information, especially in hospital settings and ambulatory settings. We're in the 90s as far as the percentage of healthcare information that's in a digital format. The problem is there's still challenges with these stakeholders actually sharing data. Technology exists, as one of the panelists mentioned on the last panel, but some of the policies, hesitation, security concerns, there's a lot of things that have kind of halted some of that, realizing the full opportunity of all of it. Now, there's been smaller bites of legislation since then. HTI 1, HTI 2, these are rulemaking pieces of legislation that we've done, and they're helping to advance looking at responsible use of AI and other things like that. And we don't know what that next major piece of legislation will be, but we really have come a very long way, since 2004. And now we do have a largely digital environment to take advantage of, and there's endless opportunities. And that's where hopefully, we can continue to work with all of you on realizing that. So our agency, ONC or ASTP, however you want to call us, sits within the Office of the Secretary at HHS, and it coordinates across all HHS agencies, as well as all agencies outside of HHS that have some kind of a health IT, digital health component to it. So if you think of the VA or the DoD, they deliver healthcare services. We work with them on adopting electronic health records and telehealth and all kinds of other things. And then sometimes we work with other agencies like the Postal Service. I love using this example because people scratch their heads when they say, why are you working with the Postal Service? Well, anybody know how we do patient matching in this country? It's not through a national patient identifier, and we won't get into the reasons why. But we do it based on probabilistic matching, right? A couple of key data elements used to say this John Smith is that John Smith. And usually address specification is one of the most critical elements to that. And guess who sets address specifications for the country? The United States Postal Service. So we work across the federal government, and we also work with states and local municipalities, and more importantly, the public. And I'll get to this a little bit more later on. But the idea is that we have to coordinate with the industry as well to understand where the challenges and the barriers are and the opportunities are, and then to help see what we can do to help support that further exploration and adoption. And there's some key objectives there, but the idea is ultimately, like I said before, we want to make sure that all that digital information can actually be leveraged and taken advantage of. So when I talk about coordination just inside the government alone, there's about 40 federal agencies that we typically would coordinate with. On the left-hand side, those are all the agencies that sit outside of HHS. There's about 20 or so. And then within HHS, that's on your right-hand side as you're looking at it. There's actually a few that are even missing from there, like ARPA-H and a couple of others. And that's being condensed. The right-hand side, there's a reorg underway. The goal is to condense 20 agencies or so down to about 10. Many of the same functions will be there. They're just kind of getting merged into different agencies. So I won't get into all that because it's still playing out. But the idea is that there's about 40 federal agencies that we coordinate with, and underneath something called the Federal Health IT Coordinating Council. And that's something we manage. I lead the Digital Health Innovation Work Group underneath that, and it's all the innovation leads in healthcare, in digital health from these agencies. And so we talk about emerging technology trends, challenges with the adoption of those technologies, whether they're digital twins, whether they're blockchain, as was being talked about before, or just anything else that's kind of emerging, digital therapeutics, et cetera. We talk about innovation practices. How can we better partner with startups and investors and incubators and accelerators, grand challenge competitions, public-private partnerships, you name it. But we try to coordinate across government, so when we do engage externally as well, we're doing it in a more coordinated, single voice type of manner versus CMS is saying this and FDA is saying that and our agency is saying another thing. And we've seen a lot of impact through that coordination work over the years. You're probably most familiar with our work on EHR adoption and hopefully supporting as much interoperability on EHRs and EMRs. But a lot of that is going a step further and trying to provide more patient access to all that information, and then also helping to use technology to get them more access into actual care and services, and to empower them with modern technologies and smartphone technologies and apps and all of that to be more informed and engaged in their health. And to improve the healthcare delivery side of it, to give doctors and clinicians and administrators more choices of what they can deploy to deliver care. And then on the right-hand side, there's a couple of other areas that you maybe aren't as familiar with and that have evolved in the last, I'd say, at least certainly since COVID, a greater focus on integrating with public health and human services side of the data side of things. And we saw the need for that during the COVID pandemic, where we were trying to get access to information on whether it was testing status or disease spread or whatever it may be. There was a lot of challenges with that information in real time. And that's something that we've been working with them on, trying to standardize that and improve that interoperability. And then more recently in the bottom corner, we've always dabbled in this area, but we're being asked to lean more and more into this. So looking at health IT infrastructure to support more clinical trials, especially on a decentralized, multi-site, greater ability to enroll more patients and different populations into those trials so they can be more representative of the populations we hope to serve with those types of new therapies and drugs and so on. But there's a whole backbone of health IT that needs to support that. And then in the center there, you've got health equity and competition and choice being two areas that are kind of like anchors for those, right? And you hope that it kind of cuts across a lot of areas. But at the bottom, a foundational piece of competition and choice, that's actually something that is written into our enabling statute, actually, as being one of our duties and responsibilities. So, how do we support innovation? What role do I play in that? I'm going to give you a couple examples here that hopefully, again, will spark some of your interest. Well, going back to the HITECH Act, again, which is the piece of legislation that created our agency as a formal federal agency, there's a couple of duties that were all laid out in there, and a lot of people don't read this far down in the enabling statutes and legislations, but two of them, not that all of them aren't great, but I wanted to highlight two of them because I think they align the most with supporting an innovation agenda. And that's going to be a more effective marketplace and greater competition. And those, I think, are pretty awesome responsibilities. If you think about the magnitude of them, like how can a little federal agency with less than 200 employees and on average a $60 million budget drive a more effective marketplace and greater competition? Well, on our own, certainly we can't. And again, we have little regulatory authority. We have a certification program for EHRs, and we can enable a lot through that because so many things go through an EHR or depend on EHRs for data. But really, it's through our coordination role and working with all those other agencies, those 40 agencies I mentioned there before. That's where we can hopefully have a bigger impact, right? And looking for connecting those dots across the agencies on the opportunity, helping them get access to data, whether it's CMS to understand new payment models and their effectiveness, or even for just more efficient claims or more efficient prior authorization. Whatever it may be, that's where we hope to try to convene and coordinate and then have that impact. But we have to do it with industry. We have to do it with not just government, right? And so in defining who the innovation community is, this is what I came up with back in, 2015, 2016. We're trying to think about how does government view the innovation community, right? I have a colleague at ONC or ASTP, Dr. Mason, who's from Chicago. He used to work in Cook County Health System. He's our chief medical officer and leads our clinical team. And his stakeholder community that he worries about when he thinks about health IT challenges and opportunities are clinicians, right? He's looking at doctors and frontline staff, nurses, you name it. Him and his staff are thinking about things like the burden of health IT, provider burden with it, and a number of other challenges. My stakeholder community, my constituency that I'm focused on listening to are these people, right? And sometimes that includes clinicians, right? The doctorpreneur, however you want to say it. But it's those early adopters who are implementing and testing these technologies, whether they're in a system or outside of systems. Entrepreneurs and developers who are building them. Once again, whether they're inside a healthcare system or whether they're in a garage, tinkering and building something. Or the investors, which I know there's a lot of you in this room, but you have such a unique perch and also responsibility in helping to scale these solutions and support their further development and growth. In some ways, you're the emperor from Rome who's given the thumbs up or thumbs down onto whether or not the technology advances. And you see a lot from that perch, right? You understand where your portholes are failing and what the headwinds that they're facing, and you're asking them to hit certain benchmarks, and you know what the problems are. So we have to engage with you to understand and learn that so you can make the most efficient deployment of your capital. And then last but not least, all those organizations that support the above three, right, in some way. And that's incubators, accelerators, associations, membership networks, you name it. So when we think about how we engage with them, especially the developers and the entrepreneurs, we have to think about at what stage are they in that growth, going all the way from that idea on a napkin into getting it into market at scale. And I would argue that it's going from stage 2 to stage 3 is probably where the federal government has played the least amount of a role historically. We've done a lot on early research support and funding pilots sometimes and challenge competitions and kind of sparking a call to action in priority areas. And we got a lot of tools. These examples on the bottom of each category, just some examples of tools we have at our disposal to try to advance some kind of a new priority or call to action. And each administration will have their own, and we'll deploy these tools to try to advance those missions. But going from stage 2 to stage 3 is one where it's been challenging, and that's like helping that market penetration. And this is key. If you heard from the last panel, right, you can have some of the most brilliant innovations, novel technologies, most promising things. Other industries like fintech is taking advantage of it years ahead of us, and we're laggards in it. And part of the problem is like it's not developing it so much or even validating it. It's getting it into the market that's the biggest challenge. And so, what I have been arguing for years is like we need to lean in more on trying to figure out what frictions are going from stage 2 to stage 3 and what can we do more on that space. Now, ARPA-H was launched a few years ago, and they are looking at big transformative change. They're not looking at innovation on the edges, but rather things that kind of like change whole paradigms and making big bets, taking greater risks. And if you're not familiar with ARPA-H, I got to be careful with my acronyms. That's the Advanced Research Development for Healthcare Agency. It's kind of like DARPA, but for healthcare. And so they're definitely focused a little bit more on stage 2, stage 3. And the idea is like they have a lot of technical support as well that they provide and wrap around some of their new things they're funding to actually help them get market penetration. And there's been a number of other ways creatively we've tried to do that over the years. And then at the bottom of that is making sure all that data that we now have available in different treasure troves in different siloed areas, and empowering that to be following and accessible and available at every stage to help fueling that growth. It's not just needed at the early stages, it's needed at the later stages to continue fueling that growth. So for entrepreneurs and investors, I know that this is a crowd that's usually pretty familiar with this graph here, but the innovation spectrum. And so government usually you see, again, on the left side in the discovery phase, SBIR, STTR with NIH, one of our sponsors for this event, they get very involved in helping people cross that kind of valley there and get until it can get picked up by industry investors and the industry itself and getting those deals and getting that penetration. But we are starting to get more and more involved on the right-hand side, including being investors ourselves. BARDA has, the BARDA Drive program. ARPA-H makes investments. There's a few other agencies that we've been part of. And we've been doing more coordination work, again, with investors to try to make them be more efficient with that capital. There's a source that I have at the bottom here about innovation ecosystems. That's where this came from. Deborah Jackson from the National Science Foundation authored this 10-page white paper, if you will. I think it's a fun read for those who like that kind of thing. But it talks about the champion shift idea of when you're able to coordinate together as an ecosystem, the left side tends to invest a little bit further to the right, so it shifts it right. And then the right-hand side tends to get involved earlier and make those investments earlier because they're able to vet and trust those opportunities a little bit more. And then what you see is that valley of death, shallow, and there's a plateau that's raised above it, so it's easier for more innovations to cover across that. That's the kinds of things that I'm trying to work on with partnerships both inside and outside of government. So again, the idea of leveraging an innovation ecosystem where we're all active players in it. Government's not the one in an ivory tower dictating it and setting it up, but rather as an active participant in engaging in it. We have value to bring to the table as much as anybody else. And over time, we'll be either able to engage more or less in it, but nonetheless, there should always be a seat for us, I would argue. And we need to have all the different stakeholders at that same table. But being able to also look at it based on different regions, so what does the Chicago and Midwest region do really well? And what are their specialties and their unique needs and challenges, helps policymakers, but also it helps business leaders, right? The corporates that are in the community that can help provide resources to support that environment, helps them more efficiently deploy that as well. So we all have to kind of work together. So, This is there's a lot of different quotes out there attributed that are similar to this that are attributed to different people, but the idea is that there's really been nothing in my career that I've done on my own that I feel proud of. Everything that I feel proud of or felt fortunate to be part of has been something where it was a lot of different types of stakeholders coming together through partnership, and the power of many working together, it usually advances something more meaningful, and that's why we do have to focus on public-private partnerships. Now, in the first Trump administration, during those years, we launched a platform underneath the American Competes Act authority where we can do public-private partnerships, and it clearly lays out how we can do that. We launched a platform or kind of a methodology for doing these public-private partnerships known as Innovation X. Okay, and you can look it up on the HHS website, just Google HHS Innovation X. But it became a model for how we could think of these big call to actions or these opportunity areas and corral all those different types of stakeholders I mentioned before around that issue, and then try to, again, make the most efficient use of all those limited resources. Now, the first one we did was Kidney X. The spend on dialysis treatment alone out of CMS is larger. I think at the time the study was that we spent more money on dialysis treatment through the federal government than I think it was the budgets of NASA, Department of Education, and NIH combined. Just on dialysis treatment, which I think everybody in this room would argue is not necessarily the most enjoyable experience if you're a patient or if you've witnessed a family member who's had to go through that, as well as the technology itself was extremely outdated. And again, this is going back to 2017 timeframe. And also there's kind of a duopoly in the field, right? If you look at it, there's Fresenius and there's DaVita. So it's an area ripe for innovation. That technology had been there for dialysis treatment since like the 60s and hadn't really changed in a long time. So it was one where we can create this win-win scenario for everybody. Government reduces the cost and spend, you get better outcomes for patients, better experience for patients, more innovation technology. And that was the first one we launched underneath that, raised about $25 million in private funding, $25 million in federal funding to support that, and that program's still ongoing today. Second, in the Trump administration was LymeX. It was all around Lyme disease, kind of a similar model, around $25 million raised, et cetera, issuing non-dilutive grants. Great program. Still going on today. And actually, Kidney X might be winding down, but LymeX, I think, is going to be expected to continue. Then we ran Pandemic X and Cancer X in the Biden administration, all underneath that methodology as well. Pandemic X was a one-year program. We had special funding from Congress to do a one-time program on that. But Cancer X is one where actually we used near zero federal dollars. It was pretty much all private funded, and it was just the platform of government setting the table, inviting everyone together. And this is the most recent one. This is the only reason why I'm flagging it. But the idea is, it's a multi-pronged effort to try to bring together the field of oncology around digital tools and getting them into the market faster for that field of oncology. And so at the anchor piece of that is a startup accelerator. We've put about 30 startups through that accelerator, had about 300 that applied for it over the 2 years. And they're also focused on a little bit of a later stage startup. So the idea is getting ones that are market ready, they have an MVP, they've already got some revenue, they have a real team, and it's a real company, getting them all the access into the market faster to meet the demand of the marketplace. This isn't government saying this is demand, this is bringing together the market to say what's the demand, how can we better help get you aligned there. And then engaging government in that, having the National Cancer Institute, having FDA, having our agency all work with them on data standards for oncology to help support these digital tools and everything else. You can learn more about that or talk to me later as well. And then there's a couple of other examples. It's not just these big public-private partnerships that support startups, but it's something that people don't think about as a way of supporting innovations. We put out a lot of requests for informations, or sometimes creative funding opportunities, or requests for proposals, whatever it may be. I had to flag this current opportunity for my colleagues at NIH, who unfortunately couldn't be here today due to some travel restrictions, and I live in Chicago, so it's very convenient for me to be here. But nonetheless, this is we just actually partnered with Together Health, which is an incubator kind of national ecosystem organization, to do a webinar last week. The link's there. You can watch the webinar if you want, or just go for more information on here. But there is still funding available for this program, and if you're not familiar with SBIR, Small Business Innovation Research Grants, they're non-dilutive, which is beautiful. There's a little bit of a badge of honor if you actually get an award, whether it's phase 1, phase 2, or phase 3. The idea is that there's some sort of formal vetting to it. It's a pretty rigorous process. So you should be a badge of honor if you get that funding. And for investors here, I'm sure a lot of you like to see that somebody received SBIR funding. doesn't impact your cap table, which is great. But the idea here is, again, there's some priority areas here. The money is available. Proposals are due June 10th. Decentralized trials is an area of interest. There's health disparities are areas of interest. So definitely take a look at that. The other one is we just released a request for information. And this is one, again, a lot of entrepreneurs or investors don't necessarily track this stuff or think to comment on it. But if you don't, you're leaving it up to the voices of the lobbyists for the big industry incumbents and tech firms that are shaping the rest of it. And then you complain later how you can't integrate with their platforms or they're shaping the market. Well, being able to comment on these kinds of things gives us that type of input where we need to balance those considerations. And again, some of those key priority areas, if you look at, like, again, driving the development and adoption of digital health for management and care navigation applications. That's something that was talked about earlier. And then, looking at, reducing administrative burden, accelerating progress towards value-based patient-centered care. These are all very relevant, needed areas, and CMS has their ears open. They just launched this. We're partnering with them on it, looking at the tech side of things to enable all of this. So please spread the word. Comments are due by June 16th. We're still taking that. So with that, I hope I didn't go too long, but it hopefully gives you a sense of some of the things that we're working on and we'll continue to work on. The federal government does always have a certain number of tools in the toolbox. Each administration will decide what they want to leverage out of that toolbox. It's people like me who try to flag those opportunities for them and say, hey, you want to advance work on food nutrition? Well, here's some of the ways we can do that, right? We can have a public-private partnership on food nutrition and bring out of the woodwork all of the entrepreneurs and innovators and people who are working in that space to do that. So, but with that, I'll take questions, and hopefully you guys will be somewhat friendly.
Thank you, Stephen.
And apologies in advance for anything I have to punt on. I was stretching my leg out this morning just in case, but I hope not to. I hope to be able to address as many of your questions as I can.
Thank you, Stephen. Yeah, we have a question right here, so we'll just go right over there.
It's a friendly one, so you can chill for a second.
All right, cool.
Stephen, Gene Paranak, Managing Director into Being and on the Med Health Board in Southeast Michigan. We enjoyed a nice time with you. At the summit, helping with your Pillar 2 in the middle there, you came out to talk to our cluster.
Love Med Health. Great group.
Appreciated your trip. And the question is, again, you may have to punt on the specific of it, but I wanted to communicate what we're seeing right at the moment with a lot of our med device company clients. In fact, a lot of their investors are saying, and again, not your domain, but FDA, are they still there? Should we really still pursue innovation? Should we really invest in innovation, which we're obviously all concerned about? And we're sort of looking at them and we're going, well, if there's a user fee related to it, I think they're going to really be eager to do it because that's new money coming in the door. And if there's not, maybe not. Maybe they won't be so interested in doing it. Do you have any, just in the current period of uncertainty as you're thinking about innovation, and I'm focused on device side, any guidance? Because we're actually talking to people who literally don't have a clue what's happening, and they're like, well, we think FDA is going away or something like that. And we're trying to tell them, no, if there's money there to do the job, they're going to try to do the job. How would you guide us?
Yeah, I wouldn't expect FDA to go away, completely anyway. They certainly have been impacted by cuts. A lot of the colleagues I work with on the digital health side, specifically, are still there. In fact, they were very impacted very little by all the cuts that have happened so far, or the resignations that have been put forth so far. So the Digital Health Center of Excellence is a team that we worked really closely with in the past and continue to work very closely with. In fact, I was on the phone with one of their team members just a few days ago. So, and they are very much interested. In fact, there was an investor out of California that reached out to me and said they had a question about something, and who did I know over at the FDA that I could connect them with? And I connected them with somebody, and they were like, oh, great, I didn't realize they were still there, because they actually knew that person already, but they failed to reach out to them on their own. And they were like, yeah, happy to talk to them and answer any questions they could. They know what they can and can't say, but certainly point them to guidance and how they're currently thinking about things. And as of right now, I'm not aware of that office being impacted. From what I understand, they're planning to still be there, partially because they are supported by user fees, and therefore it's not, if you get rid of them, it's not really saving any money on the federal government side because the industry supports that, as far as it. So.
Thank you for the question. We have another right over there.
Hi, Steve. Oh, okay. Thanks for making your presentation. I'll represent the entrepreneurs in the audience. For those of us who are caught in the abyss, where we've been funded by an STTR Phase 1, we're in the midst of the SBIR process, and then we're caught up in your reorg. What advice would you give us? And can you look into your crystal ball? Because, again, just like my friend over here with the FDA, it's the same thing with, SBIR funding. It's like, will it be there? Won't it be there? Are you going to be a survivor or not?
Well, if you're not already looking at it or taking advantage of it, I definitely, that one slide that I had up there on the current funding opportunity, that money is already appropriated and has been cleared by this administration to go out the door. So that's something that they were cleared to speak on and do webinars on, and they want to get as many proposals as they can. So that is one. Now, beyond that, the budget negotiations that are going on right now, and that'll continue over this summer, will, and ultimately what we get in place for October 1st will dictate a lot of the reality of the new kind of environment for federal funding and structure and all of that. A lot of the changes that are being made right now are signaling what they want to have happen, but Congress controls the power of the purse, and ultimately whether programs go away or reorganize, all of that will be buttoned up, so to speak, in the next budget cycle. So there's a lot of dust kicked up right now, as there always is in any change in administration, right? So this year maybe a little bit more dust than usual, is one way to say it, but nonetheless, it is one of those things that kind of happens in the first 6 months to a year of any new administration, especially when it changes political parties. You always kind of see a reestablishment of agenda and priorities, and trying to get their hands around where the money's being spent and so on. And obviously, in this administration, we know they have some other broader goals about about limiting funding and shrinking the size of federal government. So.
Thank you so much. Unfortunately, that's all the time we have for questions, but thank you, Stephen. I believe we have a networking break after this if anyone would like to approach Stephen with any more questions.
I plan to try to stick around most of today and tomorrow, so just find me in the halls. If you don't see me, it's probably because I stepped out for a call or something, but I plan to be around.
Thank you.
Yeah.